help? First of all, it can help research. We know that PROMs are increasingly used for RCTs to identify and measure the impact of interventions. Is drug A trial on a trial better than drug B trial? And there's been a long history of using PROMs as an outcome measure for the effectiveness and cost effectiveness of many treatments and trials. Is this operation better than that operation? PROMs are used there. And also to evaluate the impact of policies. This is more challenging and more novel, but again, you can use that if there's a new policy, and does it change outcome? And you can longitudinally measure the impact on policies. Okay. It can improve the clinical management of patients. At the individual level, clinicians may use it to prompt and to support clinical care. And also, it's argued that it can improve the performance of services. So you can aggregate data and incorporate it into the process measures as outcome measures, looking at quality registers and clinical audits data. And increasingly, there's a desire to do this more routinely. So we know the use of PROMs in research to improve care. We talked about the widespread use of PROMs in RCT already, to look at interventions and policies. Is slightly more challenging. Now, England have had it's been more than 10 years in doing PROMs routinely in elective conditions like hip and knee operations, hernias and varicose veins in the past. And so we have some data from hip and knee replacements from PROMs and trying to evaluate policies. There are some challenges. We know that this is surgical rate in the bottom by how many hip knee operations, knee replacement operations is done. And this is mean preoperative Oxford knee score. So the higher, the better their knee function is, the lower, the worse. But we can see here that actually you would think that those that are doing more areas, hospitals that are doing more operations would actually, you'll probably expect there's actually no relationship in this figure, but you might expect actually that to be less severe because you're offering way more, but somehow there's no relationship between the two. It's very hard to explain why, unless you think, when we looked at need, demand, and use, some of us may be, maybe there's lots of unmet need. So actually, if you increase the rate of operations, there's still lots of need, so everyone is just as severely affected. But are there lots of people hiding, and there's a lot of unmet need of knee replacement? Really, it's hard to explain, but this is what the data showed. We also show that hospital volume has no impact on outcome. So the more, hip replacement operations a hospital is doing doesn't really make them have better outcomes. Everyone's sort of clustered. So there's a little bit of a flatted line, a little bit maybe, but it's not really interesting finding. Difficult to measure quality if everything is flat. Provider competition also has no impact on outcome. So the most competitive market and the least competitive market. So we talked about patient choice. Well, actually, it doesn't really change outcome that much for hip and knee. So there is another theory that PROMs can improve, another aspect is that PROMs can improve clinical management of patients. And really, there are 4 ways PROMs can do this. First of all, it can support and improve communication. It can prompt patients to reflect on their health, support dialogue, enabling the patient to tell their story, and gives patients permission to raise issues. It's often that, it's a very structured, so when, it validated tools. So it actually asks aspects, like a variety of aspects of particular function developed by, clinical and patient consensus usually. So if that question comes up, it might not usually come up in the consultation. And research has shown particularly some more sensitive kind of conditions, like on sexual behavior, sexual health, it might not be immediately apparent to the clinician to ask that question, but if it's been completed by the patient or the clinician completes a PROM together, it might prompt patient to either raise it and say, oh, I saw this as a question, I'm actually affected by it, etc. And actually enables the patient to have a further dialogue. It supports greater focus on the patient's interests and the idea that it should improve the appropriateness of care. And also maybe better detection of adverse problems and adverse outcomes. So sometimes it's used as a screening tool. It's included in the beginning of a consultation, so everybody does it. And when the clinician sees it in front of them and said, oh, well, this patient's got a post-operative score of much lower than what I'm expected. I'm going to ask them X, Y, Z. So it can actually detect adverse problems. Some clinicians use it to say, to help them differentiate whether or not patients should come back earlier or later for a review, for example. And hopefully also improve efficiency for the symptom system and the patient. So for example, monitoring long-term conditions, patients can actually log on and complete a PROM on repeated times to look at their own symptoms and also alert the clinicians to any changes in their symptoms. So one of the examples is Parkinson's.net in Denmark, and they have in the Netherlands, in a Dutch registry. And they have 50,000 patients registered in a national regional network. So essentially, very concerted effort into focusing on patients' concerns. So patients can actually report their PROMs outcomes, patient-reported outcomes, and is linked to their experience data and their clinical data. So clinicians can log on, patients can log on, and it's actually shown that it focuses the clinical care for these Parkinson's disease patients to their clinical concerns. It improved patient-reported outcomes. Basically, the quality of life and function has improved. It's helped prevent other side effects, hip fractures, etc., and also reduce costs. We have a successful network of using PROMs to manage clinical disease. As the final bit is the use of PROMs to improve performance of services and the challenges to that. There's lots of support and encouragement for using aggregated data PROMs to compare different hospitals and practitioners and consider trends over time. And there is actually a belief that this will improve the quality of care. But the question is, how does it do that? Well, actually, PROMs is very new, and let's have let's think about why it may and how it can. And actually, there's a lot more need for us to research into how we can better use it and how we can use it to improve care. Policymakers, and we said there's a clinical willingness to want to measure, but the reasons for how it can do that, well, it's rarely made explicit, really. So there are really some theories that lie behind these beliefs. And these circumstances are context dependent and how PROMs data could improve care and what mechanisms it can to help improvement occur and what evidence we might ask to support these theories. Let's talk about these in turn. So first of all, the three underlying theories: supporting patient choice, improving accountability of providers, and enabling providers comparisons benchmarking is supposed to help improve quality. Okay. But we know that this is influenced by context. First of all, the degree to which the data is publicly disclosed. Sometimes PROMs data is kept very secret, hidden behind managers' paper files, behind administrative tasks. Oh, it's just another chart there. No one knows how to use it or interpret it. Use of financial incentives, very similar to the question about clinical guidelines. Oh, well, it's there. How do people use it? Do people use it to change their clinical practice? Do people use it to improve care? Same kind of questions. How do we use financial incentives and sanction to support best practice? Perceived credibility of the data. something like a disruptive technology, if PROMs is seen as a disruptive technology, is new, the familiarity with seeing it, clinicians are not trained in the same way. You see a blood test, you know what to do with it. You see a PROMs data, Oxford HIP score, you might not know what to do with it unless you understand it. And if you see your hospital as an aggregated data on how the patient's PROMs were compared to another hospital, unless you really understand how it's collected, the use of it, and understand what it's for, that subjective measures are equally important and trustworthy, you might not see it as credible. And also the extent to which the data can help identify actions. And I think this is really important. A main point is sometimes it's not directly obvious for us when the relationship between outcome and what we can do to improve that outcome. Sometimes it is, but sometimes it's not. But unless, for example, inputs is, there's no soap and water, you can provide soap and water, and that would be an immediate change in practice. But with PROMs, it's actually, it gives you a smoke detector, a detector on how it works. It might be what aspects you might want to look at, but how you would actually get it to improve needs a deeper dive. It needs other clinical processes, and it needs a complementary data, and maybe a deeper dive to understand how to decide on actions for improvement. So there are 9 mechanisms by which care may improve. Let's look at these in turn. So we talked about supporting patient choice. We talked about improving accountability of providers by benchmarking, and then enabling provider comparisons. Okay. The theories behind each is interesting. So supporting patient choice, we think that patient will choose higher performing hospitals. So in the NHS, actually, there is a patient choice, so you can choose which hospital you go to. In practice, this happens a lot less than we think. It depends on the service, and it depends also on the availability of hospitals. But usually, but the theory behind it is that actually patients might choose a hospital with a better outcome, better PROM, for example. Threat of loss of market share and poor quality providers will then exit the market. And this is much more for a market model. And in the States, certainly, this is used a lot more. Then there is improving accountability of providers. Threat of sanctions. We know that if your PROMs fall outside certain statistical boundaries, or if you consistently poor performers, you could have a sanction. You could have a regulator and sanction. You could be your service could be stopped, etc. And there could be the idea of how we can drive improvement with outcomes. And enabling provider comparisons. Essentially, this is where actually there's a lot more emphasis on now, is about professional ethos. Usually, there's a lot of pride for clinical practitioners to want their organizations to do well. If for districts as well, commissioners, public organizations, their reputation is important. And so if they know that their outcomes will be published, there's a drive to improve care. There's a belief that this will have focused the concerted effort to provide better care. And also the idea that you can have a sort of peer-to-peer learning and peer-to-peer review, that those who are the best performers can help disseminate knowledge and best practice and influence the community in that way. So much more of a supportive, perhaps, aspect to it. So different reasons how, different combinations of how it might help improve care. There is little evidence for some of these. For example, patient choice, there's actually very little. I've already let you know that actually patients tend to choose, it's variable, but patients tend to choose their local hospitals, at least in England. They tend to just go to the closest one. I don't know about your country, that might be different. Well, improving the accountability for providers, and it's, there's some evidence on this, a little bit more, that, for example, if it's publicly reported, so it's transparently reported. If the clinicians accept the metrics, again, this is very, if there's large clinical drive, there is more successful. What the financial incentives are, and if the national data is consistent with local data. So again, these are all context dependent. And the ability to identify actionable causes, and this is important because there's been research into the effects of effects of PROMs, and some clinicians are saying, well, actually, we know we're not doing well enough, but actually, there's a lot of work to understand why we're not doing that well. And if there's a simple change needed, then it usually leads to faster improvement. And also, there are some dangers in perverse gaming and things like that, as all data has when we collect and measure assessing quality. So when we enable provider comparisons, we find that when clinicians own the data and it's credible to them, it's much more helpful. And if the feedback is timely, it's been said that they can do much more with it. And the feedback provides advice on causes and remedies as extra bonus. So this is what the clinical community wants. So with the clinical data, if they own the data, they're able to use it more. And also the desire to be seen to be good by peers and the public as a stronger evidence of desire. But we did mention that when we looked at some of the data I've shown you in England at least, there isn't a huge amount to say overtly that actually this has improved care or it has measured differences in care. But a lot of it is maybe to do with the types of clinical intervention that PROMs is currently used. A lot of it is in elective care, where we know the outcomes are already very good. So mortality is very rare in hip and knee replacements, in elective care and generally. And we know that actually through research and through many years of collecting it, that it's a very cost-effective treatment. And so probably partly to do with the reasons why there's little evidence on how effective it is based on what is being assessed.